so much for joining us today for the Georgia Center for Diabetes Translation Researchers monthly seminar series. Can you guys hear me? Yeah, okay, great. Today we're pleased to have a presentation by Dr. Rosette Chakkalak. I'm sure I pronounced that incorrectly, I'm so sorry, on identifying opportunities for innovative diabetes translation research through routine clinical practice. Dr. Chakkalak joined the Emory University School of Medicine in December of 2021 as an associate professor in the Department of Medicine. Her research focuses on reducing the burden of type 2 diabetes in high-risk populations with funding from PCORI, NIH, the CDC, and the Tennessee Department of Health. She has led studies analyzing type 2 diabetes medication use and the National Patient-Centered Clinical Research Network. Dr. Chakkalak tests strategies to improve type 2 diabetes prevention and management in clinics serving low-income communities. She examines permpartum weight management in women with gestational diabetes and evaluates the implementation and dissemination of the National Diabetes Prevention Program. So without further ado, we welcome Dr. Chakkalak, and we're so pleased to have you join us today. The floor is yours.
Thank you, Jeff. So I'm going to make sure I actually get my slides up. You guys seeing slides okay?
Yes.
Okay. I was going to say the silence is usually a good sign. So thank you all for inviting me to speak with you today and to kind of go through some research that I've been able to do that I hope is an area that we'll get to continue to develop together here at Emory. I've put a lot of information into here, but I really do want this to be conversational and informal. So I'm not great at being able to see the chat box while I'm speaking, but Jeff, if you pop on, or if there's questions that are coming up along the way, I'm very happy to take them as we go along. Or if you want to save for the end. Okay, yeah, I was going to say, just someone flag me down. Much of what I want to talk about today is just work that I've been able to do, that I've identified the work through my routine clinical practice. And so that's why I kind of labeled it this: identifying opportunities for innovative diabetes translation research through routine clinical practice. And to give some background on why I come at it from this direction, I am a primary care physician, and actually my path to research came through primary care. So before coming here to Emory for residency, I completed my medical school education at the University of Miami and the Miller School of Medicine, where I was very active in an organization as well called the Department of Community Service, or DOCS. When I was updating the slide, I was looking at all of the docs materials, and they look so fancy and updated. But back when we were doing it a while back, it was pretty much a homegrown organization where we did community health fairs that were very much focused on diabetes prevention, detection, prevention in the Miami neighborhoods. So we would go to communities like Little Haiti, Little Havana, down to the Keys. We had a student-run clinic, but working in Miami, going through kind of the DOCS program, I was very interested in pursuing a career in primary care medicine and staying very clinical. I really liked working the community sites and working with the patient community that I got to meet there. I came here to Emory as an internal medicine resident, and I specifically focused on primary care in my training by joining the primary care track, which at that time was Dr. Brady and then Dr. Higgins, who were in charge of it. And then now Dr. Fluker is in charge of it. And I will always say that was one of my best experiences in training, was being here and getting to do the primary care program, because it's a fantastic way of getting a very strong background in categorical medicine, as well as primary care in safety net settings and in general. And as a resident, I feel like I got a lot of exposure to that next step of diabetes, which is diabetes management. So as a student, had done a lot in prevention and awareness. As a resident, got to learn a lot more about management, and also met this group, the CDTR group, met Dr. Narayan and Dr. Ali while I was here as a chief. But really, through much of my training time, I was thinking I'm going to be a clinician. Probably halfway through residency is where I started asking a lot of questions, where someone told me, you should really be thinking about research. And I was like, no, I want to be with my patients. And they said, right, you can do that with research too. And so I was really being encouraged by some wonderful mentors to put the idea of, can I be using the real world data that I'm seeing being collected in clinical settings? Can I put that to work for me by answering some of the real world questions that we see in routine clinical practice? And again, through some really great mentorship that I was offered by when I was here as a resident, I learned about the Robert Wood Johnson Foundation Clinical Scholars Program. And the program was a great opportunity for me to learn how to connect those dots. So if you want to be in clinical settings, but you want to be able to use some of the information you're learning there, gathering there, questions you're developing there, and move those into kind of research questions that we can ask, rigorously evaluate, design good studies, this is what that program focuses on. And as an example of that, when I first started in the program, I was really interested in something I learned a lot about here, kind of through my clinical training as a resident, but also very much through listening into conversations with Dr. Narayan and Dr. Ali. I was really interested in looking at acute myocardial infarction in Asian Americans. I was really just interested in the space of cardiovascular disease in South Asians. And one of the first questions that I started asking after seeing it clinically and understanding it clinically, that we had a lot of information about cardiovascular disease, AMI rates in our communities across the US, I started asking this question of why we don't see published numbers out there very accessibly for AMI rates in South Asians living in the US, or for that matter, very many Asian American groups. And my mentors in fellowship pointed out to this data source, the Healthcare Utilization Project, which back then was something that lots of folks were already using. And they said, this may be a good place to ask those questions. It was a resource of electronic medical record data that could be used to calculate rates of disease, look at complications, outcomes. And when we started looking at the literature, we noticed that even using HCUP data, you wouldn't often see reporting out for Asian American communities or specifically for subgroup communities within HCUP. And a lot of that had to do with the way in which we collect data about race and ethnicity in clinical settings. And so I'm not going to go into too much detail with these, but much of my work as a fellow was really looking at what we do in clinical settings to collect information about people's race and ethnicity. How do we ask those questions? Do we get them to self-report this information, or do we assign race and ethnicity based on what someone looks like, which we shouldn't do? But it was very much informed by my own experience of how do we do intakes on patients when they walk through the clinic doors. And we did some work where we really analyzed HCUP data, not so much for what is the AMI rate, but what happens to that rate, that actual number, when you change the way you collect the data, when you look at states that actually look at subgroups versus those that don't. And recognizing that a lot of loss of data or loss of understanding was happening because of the aggregation of all the subgroup data, or not even asking subgroup data, into a very broad category of Asian American. So for me, it was a great introduction to learning how you can use real world data that's collected. So this is data that comes from clinics and hospital systems, gets organized into common data elements within the electronic medical record system, goes into HCUP, and then we as researchers can pull it out and ask the real world questions that may be coming to mind when we're in clinical settings. The other place where I really was able to learn quite a bit about how you can use data from routine clinical settings to start asking some important questions is when I started working more formally with the National Diabetes Prevention Program. So again, this was an opportunity that came up for me while I was a fellow, and it was fantastic because I was working with a federally qualified health center that was already running a national diabetes prevention program. By working with them clinically, I was able to learn what was involved in the program and really understand the nuts and bolts and how it came to be and how they were operating it. So literally going to the school where we taught the program, sitting in on sessions, collecting data with them, learning how it worked, kind of got that understanding down. And then when I moved into my first faculty position at Vanderbilt, started working with the diabetes prevention program there as well, and learned a lot more about the data collection elements of it. So I think in this audience, many of you know that DPPs that are working with the CDC on getting fully certified participate in a program called the Diabetes Prevention Recognition Program. This is a very extensive program of data collection, and it's essentially meant to make sure that DPPs are running at the highest quality possible and that they're achieving the outcomes that have been specified for the DPP long term. But when you are running a DPP, this seems like a very cumbersome process of collecting a lot of the data that goes into data submissions to the CDC. The great thing from a research standpoint is that this is another example of where our routine clinical practice organizes data for us that can then be used for really strong research and evaluation questions. And for me, it's been really helpful. I basically did a deep dive into understanding the DPRP, working hands-on with the program as they continue to maintain certification and get their certification through different platforms. And we've been able to do a lot of work in program evaluation and implementation science that's built off this structured data that they use for the certification program. So early on in fellowship, I worked with our FQHC where we were able to kind of get a paper out that discusses how you put the program together to make sure that it can go up for certification. While I was at Vanderbilt, I worked with their workplace wellness program to evaluate the program that they already had in place, but that evaluation was very feasible because of the structure of the data that we collected. And then right now, I continue to partner with that group at Vanderbilt on an R01 award where we're really looking at program evaluation for their DPP because they expanded their program to go beyond just in-person group sessions to also using distance learning. They did that before COVID. It became a great intervention for them to continue all through COVID with distance learning. But again, the evaluation piece, the implementation science elements of our research project have been very feasible because of the structure of the data for the program. So for me, I've realized that oftentimes it's the availability of the data from our routine clinical practice settings and knowing how it's structured and if it's usable has helped me quite a bit in being able to ask the real world questions that I want to be asking as a clinician. I want to pivot now and spend most of the time of this talk to really talk a bit more about PCORnet, because I think this is a great opportunity for us to think about, again, real world data availability to answer real world questions. And it's a newer resource that we have available to us at Emory as well. And I've had the opportunity to work with them quite a bit at Vanderbilt before and now move some of that work here. So I've borrowed slides from a few different places. If you go onto the PCORnet website, you can find some of these slide sets kind of giving the broad overview of it, but also with One Florida, which is a network that we work closely with, and I'll show those as we go along. The link I have here at the bottom is for that overview that's available on their website, so feel free to look at that yourself as well. So for those of you who haven't heard of PCORnet before, PCORnet is a part of PCORI, which is the Patient-Centered Outcomes Research Institute. And part of the reason I knew quite a bit about PCORI when I was first starting off in a faculty role is because while I was in fellowship, some of the leadership of our fellowship program came to be on the leadership of PCORI. And so they kind of introduced this whole new resource and said, you should know about this, you should learn about this and see what opportunities may be available. One of the big places that PCORI had wanted to make an impact was in improving clinical research. They are a federal funding agency, and so they oftentimes are a lot of people that have been involved with NIH or CDC for a long time, and they really value the research being done there. But they did identify that oftentimes some of our research that we do through traditional routes is not able to answer the questions that matter the most to people. And I'll just put a plug there to say that people term doesn't just mean to patients, but also to clinicians or healthcare providers that are on the ground. They also noticed that clinical research was taking quite a bit of time and it was very expensive. And so it wasn't necessarily getting out to the settings that we needed, that we wanted to have access to either the clinical research study design or to the results. So PCORnet was created to make research better. It's a network of networks with curated electronic health record data from 66 million highly representative patients accessible for observational studies. PCORnet has really been built off of huge teams at academic centers, community centers, other health systems who have expertise in integrating research and care. And they really do mention this emphasis on streamlined processes and being patient partnered. To get into that a little bit more, you'll hear this term of clinical research network or CRNs quite a bit when we talk about PCORnet, but they say that CRNs combined with patient partners and a coordinating center is what gives researchers a national infrastructure for people-centered clinical research. And a lot of their, when they talk about this resource, they really do talk about it as a network of networks, and we'll get into that in a second. So taking these slides out of order from them because they kind of have a rhythm to it, but I think this makes a little more sense for what we're talking about. One of the key features of PCORnet that I think makes it very helpful for those of us that are interested in asking these questions based on what we see in in clinical settings is that they use a common data model. So they may be fetching data from multiple different electronic health record systems, but to make it usable, we have to be able to say that what we're looking at is the same across systems. So they have organized it into a common data model. They have some categories of data that's already ready for research. So the ones that they have, they're listed in green. The key ones that I would mention are diagnosis codes, medication orders, claims, labs, demographics, and procedures. These are data that are readily accessible already now if you were to partner with PCORnet. In blue, they highlight the ones that they want to make available as PCORnet develops. I will say that some network partners, some CRNs already have good ability to access social determinants of health data. There are some groups that are really working hard on natural language processing. Some already have connections to tumor registry. But essentially, this is really valuable electronic health record data that they put into a uniform format that can be used for research across the nation. And this is not a novel thing. So I think for folks that have done research like this for a long time, we've seen a lot of resources come through that make use of electronic medical record data. But I like this slide because it summarizes kind of how PCORnet might stack up to some of the other resources you've seen before. So the formatting of how they've organized this system makes feasibility queries possible. You're able to look at identifying patient populations for trial recruitment. So not only can you look retrospectively at the data that they have available in it, if you work closely with a CRN, you can actually recruit patients from their network. You can do coordinated data curation and make connections to patients and providers. I think the connection to providers is also quite important, meaning that you can actually partner with clinicians at sites that are participating in a CRN. And again, think about it for using things for prospective studies, not just retrospectively. And then here again, we bring up this concept of the CRN, the Clinical Research Network. So for me, part of the reason that I started working with PCORnet is when I was at Vanderbilt, they were the group that started the STAR CRN, that purple colored CRN in the middle. And I had a great opportunity to work with fantastic mentors like Dr. Russell Rothman and Dr. Christiane Rumi, who were really building the infrastructure for a CRN at Vanderbilt. By learning at Vanderbilt about the STAR CRN, it became a huge benefit to me when I was able to move here to Emory to get involved in the One Florida Plus CRN, because Emory had just recently joined that CRN when I came here. So I think this is part of the reason that I wanted to bring this up as a resource that we could talk about in the seminar series together, is to just point out that we have a great resource that we're now a part of and could open up a lot of opportunities for a lot of us in diabetes translational research here. The other ones that are on here, I won't go into them in depth, but just to recognize that each of these CRNs is in their own region or their own network of healthcare systems. But remember, the really key thing is that they are all inputting data into a big system using a common data model. So in theory, you could query from all of these different CRNs, and I'll give you an example of how we've done that before. Okay, so I mentioned already that some of my experience with this has been working with the STAR CRN, Clinical Research Network. So the STAR CRN was started at Vanderbilt. You can see on here that it mentions the other partners that are involved with it. So VUMC, Vanderbilt Health, Meharry, Duke, UNC, Wake Forest, the Carolinas Medical Center, and Mayo Clinic. When Russell and Christiane and others, the leadership of STAR CRN started it, one of their really important areas that they wanted to work on was how to build capacity for diabetes translational research using the STAR CRN. And so a project that I was able to be involved in very quickly was this one called Diabetes Incidence, Prevalence, and Medication Views. And this was through a funding mechanism called a PCORI Rapid Cycle Research Mechanism. And I'm not sure if they have these anymore, but at the beginning of PCORnet, they used this mechanism to basically say, okay, we're building PCORnet. We want to see what it has the capacity to do. So they also would make these smaller awards, kind of like a supplement, to see how it would work to, if you wanted to look at a cohort of patients with diabetes, it was focus funding to be able to look at that and just see what the performance of PCORnet could be for this kind of population. And so that's exactly what we wound up doing. We wanted to investigate the performance of different computable phenotypes for the identification of patients with diabetes. We looked at the prevalence of diabetes between 2012 and 2017 study period, which was like basically we were trying to figure out for all the data that was available in PCORnet at that time, what was our prevalence. And then among patients with diabetes, describe patient characteristics, availability and reliability of relevant lab result values, and characterization of missingness patterns in each cohort. So I think, as you can tell from our objectives, this was a project really focused more on understanding how PCORnet could work for these research purposes. We obviously wanted to get some information about our patients with diabetes, but we wanted to also see, what data can we pull for these folks with some reliability. These slides that I'm presenting here, Christiane Rumi put them together for a PCORnet report out. And so we'll kind of go through them in some detail, but maybe not all, because we were kind of going in detail for that presentation, but please feel free to stop me if you have questions as we go through. So the first set of data that I want to show you is what we published eventually about performance of our computable phenotype for the identification of patients with diabetes in PCORnet. Again, for folks that have worked in electronic medical record data-driven queries for quite a while, this is kind of a fundamental first step, which is saying, okay, we have a bunch of data available to us. We want to be able to study folks with diabetes, both retrospectively and prospectively. But first, we got to figure out that if we run a query of people with diabetes, are we actually capturing people with diabetes? And so I'll also credit Dr. Weissy, who was a postdoc with us at that time, did much of this work. And so what we wanted to do is define a diagnosis of diabetes in PCORnet. So we looked at 3 different criteria and combinations of those criteria to come up with our computable phenotypes. In the first one, we defined diabetes as an ICD-9 or an ICD-10 diagnosis code for diabetes, as well as a diabetes medication within 90 days. By our second definition, we took the diagnosis codes and an outpatient A1C of greater than or equal to 6.5 within 90 days. And for our third phenotype, we said that it was a diabetes medication and an outpatient A1C greater than or equal to 6.5. So to fall into our cohort of patients with diabetes, you had to meet one of these computable phenotype criteria. And this is just an example of, as we build these phenotypes, this is a key step to it as well. You're basically going to be thinking through all of the diabetes medications that you would count as a definition of diabetes. And I think for those of you who are clinicians in diabetes care, you can tell that these have probably changed significantly even from when we did these. So this is something that's a dynamic process within PCORnet polls, data polls. And so this was a collaboration. This slide kind of summarizes the project in general, but we did this as a collaboration within STAR CRN. And at that time, we used to call ourselves the Mid-South CRN. But within STAR or Mid-South CRN, there's multiple institutions. We partnered as 4 of us at that time to be able to do this. So it was Vanderbilt, UNC, One Florida, and Tulane worked together to do this. And really what we were doing was chart review. So this was a fantastic project for people that wanted to get involved in clinicians who wanted to get involved in research. And we had several junior folks working with us on this. But what we did was we ran this query within the data pools that we did from PCORnet. And then we asked STAR CRN programmers to pull a selection of charts that were pulled out of that query so that we could go back to the medical record and verify that these charts that they pulled for us were actually identifying patients with type 2 diabetes as we wanted them to. And as you can see, we did a pretty hefty chart review at each site to be able to look at our positive predictive value of that query. So we did about 400 at Vandy, 400 at each site actually, and we defined them by computable phenotype as well. So we pulled the majority of our charts based on CP1, but we also did some for CP2 and 3 and went through to calculate our positive predictive values. Overall, it was quite good. We had a PPV of 96.2%. And so we knew that this was working pretty well if we were using one of the CPs that we developed. We then wanted to take that next step of what we outlined in our overall project goals, which is to say, okay, we think we have a computable phenotype that's identifying the correct patients with type 2 diabetes in PCORnet, but now we want to know something about them. And we also want to make sure that what we find about them matches what you would expect to find about a cohort of patients with diabetes. And so in this paper, which Dr. Bachman was the person that we worked with. She was one of our junior faculty at the time. we wound up distributing the query that we developed to find patients with type 2 diabetes throughout the network. And this is where it gets a little more complicated when you're working with PCORnet. But to get some of the terminology, because I feel like we throw these things around a lot when we're talking about PCORnet queries, we already mentioned that there's a CRN, or a clinical research network. So the CRN is kind of the hub that gets data in from multiple health systems or academic medical centers. The data mart concept is basically that. So the CRNs are getting information from data marts. And so what we wanted to do was distribute our query to all of the data marts and have them run it and say, in your data mart, look for the patients with type 2 diabetes as defined by these phenotypes, and then send us back the data that you get so that we can get a look at what do patients with type 2 diabetes in PCORnet look like. And so our poll yielded over 600,000 patients who met the criteria for a type 2 diabetes cohort. This is important to mention, which is that when you distribute a query, you're basically waiting on the data mart to respond to you. And most of the time they're going to respond as long as you've partnered with PCORnet to do that. But they may not, for example, if they have some issues with the data pool, or if they're not able to retrieve data from their contributors for some reason. These are kind of the nuts and bolts of working with that kind of distributed query system. Of the patient cohort that we were assembling, the median age was 64 years, about 50% were female and 20% were Black race. There was a median of 5 outpatient visits in the prior year for each of the people that showed up in our query. In the next few slides, you'll see ginormous tables. We don't need to go through all of this, but again, the point of this was for us to take a look and see if the demographics and comorbidities of the cohort that we were pulling together looked like what you would expect for patients with type 2 diabetes. So again, median age was 64, the distribution by race and ethnicity, and then looking at comorbidities. So again, this is coming from electronic medical record data. So we're depending on ICD-9 codes to be able to look and see what comorbidities these folks have. For us, as folks looking at type 2 diabetes, you would expect to see that many of these people also have hypertension or hyperlipidemia. So we do see a fair proportion of those diagnoses. But it was really just for us to say, does this make sense clinically? What we're capturing here, does it make sense? We also wanted to look at medications. So again, this is data that's available in PCORnet. So we wanted to be able to see of these other classes, not diabetes medications, what kind of stuff are we seeing that pulls in with these charts? For clinically, this seems like a low percentage, for example, of people to be on ACEs and ARBs if they are patients with type 2 diabetes. You would expect a higher proportion of those patients to be showing up with these medications. And you can kind of go through each of these classes and think through, does this clinically make sense? We also had an area where we were looking at healthcare utilization. So since this is an electronic medical record system, you could look at how many hospitalizations they've had, ED visits and outpatient visits, and does it make sense to think about these numbers? ED visits show up as 0, I think because of the way that we distributed the query, but the outpatient visits make sense in the sense of these are folks that would probably be coming into a system multiple times in a year. And then we also wanted to get an idea of missingness. So if we wanted to do studies looking at things like an intervention that could help patients with diabetes lose weight, you'd want to make sure that you're getting data about their weight or BMI pretty regularly by pulling the data from PCORnet. So we looked at missingness and the actual values for things like BMI, systolic and diastolic blood pressures, A1Cs, cholesterols, creatinines, and GFR. Now, the group that I was working with to do this is a pharmacoepi group, so their interest is very much in the medications use within PCORnet. And so this was a nice figure that we were able to put together for the paper. But for 42% of the patients that we pulled in this type 2 diabetes query, we saw no diabetes medications prescribed within the network. Of those prescribed one medication, the majority was metformin. And then the most common combination regimen at that time that we were looking at this was metformin and sulfonylureas. We were trying to look at newer agents, but again, the time span of this was 2012 to 2017. So we were not seeing some of the newer agents as frequently as we hoped for. But again, trying to understand what can we know about diabetes medications from this resource. So to summarize some of what we picked up from these kind of fundamental kind of studies, just understanding what you can do with diabetes and PCORnet. The CDM data can be used to identify common conditions that are highly prevalent, such as type 2 diabetes. So we know that from the computable phenotypes that we use. The pattern of medication use in the 4 sites that we looked at is reflective of medications that are common, generic, and cheaper, but we didn't see the newer classes as commonly, but that may be because of the time period we were looking at. There's a fair amount of clinical data available, and its clinical validity and representative is plausible, but I did point out to you a couple of the places where we weren't quite sure if we were capturing everything, for example, the ACE/ARB use. And in general, the drug use is the piece that we were kind of questioning a bit in looking at this. So data on the validity of drugs and patient outcomes remains uncertain in some cases, and further linkages to administrative data could be needed for more accurate drug exposure or outcome ascertainment. I'll make one comment about that. So one of the things that we started thinking about as we were looking at this data is that when you use an electronic medical record to look at drug use, one of the tricky parts of that is that you may see what is prescribed from that healthcare system that's contributing data, but you are not looking necessarily at prescription fills, which is a different thing. The other thing to think about is, for example, here within Emory, a patient may come to Emory Healthcare for their endocrinologist, but maybe not for everything else. And so you may be able to see some of their medications that are prescribed, but not all. And when you're dealing with a system like PCORnet, that's not necessarily linking every healthcare system that a patient visits, you may have some lacking data there. The same thing could be said of outcome ascertainment. So this is the reason we say there may be some role to linking a resource like PCORnet to claims, depending on the specific question that you're trying to ask, or to another administrative data set, depending on the specific question you can ask. But more to come on that, I think, as we keep seeing studies come out. So I want to move to give you an example of something that we did after we kind of did these baseline studies to say, can we use this resource to study patients with type 2 diabetes? So this is a project that's still in PCORI peer review process, which means which is a long process. So I'm not going to get too much into the details of it. But while we were doing this work on the computable phenotypes, our group was approached by a group from Cornell, so a group within that CRN that was working in the New York area, where they wanted to see if they could use PCORnet to study medication use in treating type 2 diabetes among patients with chronic kidney disease. And the specific interest here was really thinking about these patients and if they were being prescribed metformin in the ranges of GFR where it could be safely prescribed or not. And so I've listed here the aims, but aim 1 was for patients with type 2 diabetes and CKD to compare metformin to alternative non-insulin diabetes drugs, and our list of meds there, with respect to the key safety outcome of severe hypoglycemia. So James Flory, who was the PI for this project, his real interest was in saying, metformin may not be used as much as it could be in this population of patients because of concerns about GFR that have been there for quite a while for patients with type 2 diabetes. But perhaps we need to take a better real world look at it to see if it's, number 1, being used, number 2, safe to use, and maybe even better for some of the side effect profiles that we worry about with newer agents. The second aim was for patients with type 2 diabetes and CKD to compare metformin to alternative non-insulin diabetes drugs with respect to A1C reduction, and then to examine the heterogeneity of treatment effects on hypoglycemia risk and A1C response across patient subgroups. And the key subgroups that he was looking at there were subgroups by different GFR levels or stages of CKD. This project, again, was a partnership between different CRNs. So James's group was within that, I believe it's called Insight, the CRN that's up in New York. But he reached—
Rosette, can I ask a question? Is the data that you have on medication use being updated annually, or because, for example, all of these new medicines and the new recommendation of the ADA likely will change the way we treat people with CKD, that's right. So I'm wondering if on PCORnet and all of these databases that you are presented, how do you update the medication use on an annual basis?
Yes, so this is a great question, Dr. Ambirez. So it depends on each CRN, kind of. When we develop the query, we go through and verify which medications are showing up in the list. So when we're saying we want to look for these diabetes medications, they'll show us the list that they kind of keep as their data dictionary for medications that are being used. I think each CRN has its own process for updating it. So they may use like low-ink codes, and they may have a process for all of their pharmacy data that they use within this. But I will say that in having worked on this computable phenotype project and then James's project, we had to do kind of a hand update of additional medications. But they do that partnered with kind of medication pharmacy pharmacoepi teams to be able to know that we're getting them. But this is, I just went back to this while you were speaking to point out, for example, there's lots of ones here, like look at this line for GLP-1s. It doesn't include everything that we have now. So yes, this is something that has to be dynamically updated by the programmers at each site.
Yeah, thank you so much.
Yes, it's a great question. So for this project, that's a big piece of it. We had to do updates of what we were looking for. We partnered with New York sites, but also UNC was a site that was involved with this. So they were within STAR CRN, but a separate data mart. And the other thing we did here was think about that question that we had from that previous project, which is that if we're really thinking about medication use here, it may be important for us to not be looking just at CRN data, since we weren't sure how good that was based on our original studies. And so James's idea was to add Medicare claims data to our CRN data to see if we could get better drug information. And to Dr. Ampieres' point, that's also a good way for us to know that we're getting the Part D files, which are kind of CMS updated for medications as well. So again, a big part of this project was, and I'm not, like I mentioned, I can't really share too much results because it's still under their PCORnet peer review process, but just some lessons learned in working on a project like this, which is something that was developed based on those kind of first projects that were looking at diabetes and PCORnet. The reason that James's idea was to add the claims is to say PCORnet is pretty good at some stuff, so we can get good information about the cohort, we can get some covariates, we can get vitals, and we can get laboratory studies, which you can't get from things like claims data sources. But claims may be better for looking at diagnosis codes, medications, and then continuing to give you some additional demographic data. And so if you can do projects where you combine these when necessary, it may not be necessary for all, but for a project like this, it could help. Would it amplify the ability to answer that kind of real world question that you're posing? This is, again, another example of kind of the work that has to be done when you do these types of projects. So, our flow chart of how we were building our analytic sample, you first identify your PCORnet cohort. So PCORnet is pulling data from very far back. You can go back as far as 2009 in STAR. You can even go further back, I think, in other CRNs. We're defining our computable phenotype again for diabetes, but now we're adding in the complexity of we want to find people with diabetes and CKD, so we need to pull creatinine values as well. We wanted to improve our pull of information about medications, so that's why we matched it with available Medicare data that we had at Vanderbilt at the same time. Then we realized we also had to limit that to records that were enrolled in Medicare, not just at the time that they match, but also going forward, because you have to be able to look at their Part A, B, and D files over a period of time. And then finally, we wanted to limit the records to at least one Part D claim for at least one of the 3 study drugs of interest that we were doing. So the point of this slide is basically to say there is a lot of groundwork that has to be done after you start building these data sets to make sure that you've cleaned it to ask the question that you really want to ask and to identify the cohort you really want to find. One piece of this that we did at Vanderbilt in particular is that we had another group that was working within the VA who had been working on hypoglycemia validation. And that seemed like a key part of this project because we were wanting to look at hypoglycemia among the patients that had type 2 diabetes and CKD. Their work in the VA data sets had shown a positive predictive value of 48% for ED charts, identifying patients with hypoglycemia. So we wanted to take a look at that within the CRN data that we were pulling from the ED as well. Again, we did just a heavy chart review phase. So we pulled 180 charts from the CRN, asked them to match that up to actual charts in our medical record, and review those charts. 172 of them were eligible for that review. And of those charts, so the CRN said that they had a hypoglycemic episode. What we found is about 58 of them had a true hypoglycemic event, giving us a PPV of 33.7%. So these are not great, these are low. But again, that was part of the reason that this project was looking at what happens when you combine this kind of CRN data with claims. And what I'll say is anytime you do projects like this with a resource like PCORnet, it's learning as you go. You're doing the project to figure out how it works and then tweak it for the next project. So these are all pretty high value to me, I think, as a person learning the method. Okay, so finally, I want to be able to move now to where I think we can really be able to engage in this network and this resource going forward. So as I mentioned, for me, I was really excited when I came to Emory to learn that Emory had recently joined PCORnet through the One Florida Plus Clinical Research Network. This network has been around for quite a while. Actually, you may recall from what I said about the clinical phenotype development that we actually worked with One Florida when we were doing that, but it has expanded quite a bit recently, and Emory's addition to it is a great piece of this. So this gives us an opportunity to work with them. Huge institutions within the state of Florida. I have to say, I'm a native Floridian, so I also feel like this is a great opportunity to work with a lot of the institutions I've known for a long time. But the other recent additions, in addition to us, was the University of Alabama at Birmingham. So this clinical research network geographically is spanning a really interesting area, really nice group of patients, patient population, demographics, all of that. And we have access to it because we're going to be contributing data to it. This is a great graphic that I did not change because I got it from the One Florida folks, and they put a lot of animation into it that I think makes sense to us. But really what it's telling you the story is how you can access the data available within the network. So electronic health record data comes in. The data capture strategies are processed by University of Florida, the One Florida Data Trust. It sits within the data trust. They can parse it out to you as limited data sets. When you're working with them, they kind of teach you the process of being able to come up with your limited data set. You can also be working with local honest brokers if you want to be doing a more identifiable project. So a limited data set is really going to take away all your identifiers. You're really just looking at a data set that you're analyzing for retrospective purposes. If you wanted to do something prospectively, you could work with local honest brokers for a limited data set and maybe even patient contact info. This gets much more into you need to work at the local level to be able to do this, but certainly possible and very good data infrastructure to be able to do it. A couple of other key points that I like to point out about One Florida. They have this really cool interest in linking mother-baby data within their electronic health record data. So for those of you who are interested in the space of maternal health, I know there's a lot of folks here who are interested in gestational diabetes. I think this could be a really cool resource within One Florida for us. And then also just to point out, and I'll bring it up in another place, they actually have this thing called the expososome where they're able to link a lot of community level information that can be used for social determinants of health work. And bringing all of that into here just really magnifies the effect of the power of what you can use this resource for in doing research. I've mentioned it a few times before, but just to bring up the point again, this is all according to the PCORI common data model. So very different electronic health record systems contributing data, all of it gets standardized into a CDM. So when I'm saying I want to pull a particular variable, I'm getting the same variable from all EHR sites that are contributing. And then I've already mentioned this, that I think is one of the really great parts of the One Florida Plus CRN is that there's tremendous patient diversity in this sample. So the fact that this is Florida, Georgia, Alabama, we're getting a really diverse community of patients. And so when we're thinking about things like diabetes, we want this kind of spread of race and ethnicity distribution to be able to understand what lots of health services research related questions for patients with diabetes in different populations. I pulled this from their website because I really liked the quote, but the Florida, Georgia, and Alabama of today is the United States of tomorrow, older and more diverse. I think that makes a lot of sense. And again, I mentioned already this expososome data, but basically they can link in variables like air toxicants, green space, walkability, food access. Using zip code linkages, they're able to bring in data that we can really start thinking about for social determinants of health work in a big EMR data set. This diversity piece, I think, is really important when we think about the direction of health equity research and diabetes translational research that we want to do. And I'll bring that into the conversation of a lot of recent studies that we've seen about post-acute sequelae of COVID-19 and type 2 diabetes. So I think all of us in this group have probably seen a lot of papers come out recently about the risk for diabetes after COVID-19 and studying this in more depth. A few months ago, this big study came out from the VA population describing risks and burdens of incident diabetes and long COVID, a cohort study. This was back in March, and it was right around the same time that NIDDK had put out a very specific funding announcement to look at diabetes in patients who had been infected with SARS-CoV-2. And one of the things I noticed in reading this paper is that, yes, we saw this excess risk of diabetes in this population. But when you look at the population, it was older with a mean age of 61, mostly white, 77%, and mostly male, 89%. So while the finding was giving us a signal that we want to be able to investigate more, I think one of the really important takeaways that many people kind of commented on is that the results are difficult to generalize to Black and Hispanic communities in the US that experience disproportionately higher rates of SARS-CoV-2 infection, COVID-related morbidity and mortality, and type 2 diabetes. So I spoke with a person that I collaborate with frequently at UF about this, and we decided to put in an application for that supplement funding, saying maybe we can do a study like this, looking at type 2 diabetes after COVID, but let's do it in PCORnet, where we know we have a much more diverse community. And we also have the ability to maybe start looking at some social determinants of health data, which may also be really important to consider in asking this question. So again, a real world question that we're going to a real world data source to be able to answer. So this is a fantastic figure that was put together by Dr. Jitin Varghese, who's on the call with us, and he's a co-investigator as well on this project. We were really excited to get a year of funding to do this work. And one of the big things that I'm really excited about is that it gives us an opportunity to start really hands-on work where Emory and University of Florida can collaborate on this One Florida Plus network project and kind of just understand how we can do this work together going forward. Because I think both places have really great resources that we can pool to do this kind of work. Big picture aims for us, we literally have just started this, meaning that like we don't have anything to show for it just yet, but we are just starting to put our teams together and get our process going. But our aim one is to assess racial and ethnic differences in PASC-associated type 2 diabetes incidence in a retrospective cohort using the data trust, the One Florida Plus data trust, and then to be able to look at changes in cardiometabolic risk factors following infection. And again, we can do this because it's an electronic medical record data set that'll give us access to a lot of these continuous variables that we want to look at. I'm going to stop there and basically just highlight this thing that I saw within the Health Services Research Center newsletter a while back, just pointing out this could be a great opportunity, I think, for folks that are interested in this work. Emory is going to be part of One Florida Plus. They're going to be starting, they are starting to contribute data into it, but more importantly, they see us as collaborators that they're really interested to work with us. And so I think if there are opportunities for others of us within our group or elsewhere to work with them, I think it could be a great opportunity. And with that, I'll stop and see if there are any questions.
Terrific, Rosette. Thanks so much. And you're right, with this new grant, we literally met, I think, 2 hours ago. So we have literally nothing to show for it but one meeting. We only have 5-7 minutes left. I want to open it up to the floor. Any questions from the group?
So it's the grant is the new RFA that was just put out by the NIH on long COVID.
Yes.
So yeah.
This is Dr. Amperes, this is the supplement one, but not the one that's for there's like a UO1 center grant that they're trying to also put together where they're prospectively looking at folks. This is kind of one that was just meant more to exploratory look at diabetes.
Yeah, the University of Virginia just invited us, but it's been very hard to get data on how many people got COVID and what's going on with newly diagnosed diabetes and what happened to them long term. So, the Dr. Basu, there are two of them, Andy and Rita, who runs the diabetes program there at University of Virginia. If you have that kind of information, I'll be glad to put you in contact with them.
Thank you. Yeah, we had another person had also reached out. Also, I was actually talking to, so as Mo mentioned, we literally had a meeting 2 hours ago for the first time to get ourselves organized on our supplement. And I was talking to Troy Donahue afterwards, who's our collaborator at UF. I think the tricky part when we're thinking about diabetes after COVID, using something like PCORnet, is that I don't know how it'll work for prospective studies,
Yeah.
meaning because of that delay in terms of that bringing it into the common data model for analysis. Now, it can work for prospective studies if you want to use it as a tool for recruitment, but I think the complexity of defining long COVID may be the hard part for using it there. So the difference would be if you wanted to recruit a bunch of patients who had COVID, maybe you could do that if you could do it in real time.
And they want to know if this is, it can be newly diagnosed.
Yeah.
Or it could be COVID after the infection, or it can be pre-COVID that you didn't know, or pre-COVID that you knew.
Right.
So anyway, but congratulations for all of your effort, and I'm so pleased, I'm so delighted to hear your lecture today.
Thank you. I feel like
Rosette, I think Troy's actually on. It would be nice if both of you could think about connecting with Francisco also, because as you know, our Georgia Center for Diabetes Translation Research is trying to grow projects that link with Tennessee and Florida, specifically in the area of use of technologies in diabetes. And I think they have an annual, Jeff can confirm, but maybe it's an ongoing pilot program. So if we can enthuse others at UF or at other institutions, I think Miami's included, a couple of others, it would be great to get some more projects that either benefit from PCORnet or One Florida or others.
Yeah.
I think Alabama and Tennessee.
Yeah. Troy, you're going to say something?
Yeah, thanks, Mo. As some of you know, I just took over in the last couple of months as chief of endocrine from Ken Kuzi, who's focusing more on his research. And as part of that, I am absolutely excited and thrilled to foster as many diabetes collaborations as possible. So yeah, please include me and our group in adult endocrinology here. And as Rosette so nicely mentioned, we've been able to foster the One Florida Plus in amazing ways for the short period of time that she's worked on it.
Perfect. Guillermo?
Troy, it's so nice to meet you. I knew that they hired the replacement for Ken Kuzi. I'm so glad you are the man. Good.
Well, thank you. Thank you, Guillermo.
And I was going to say, just to put a plug out there, literally once I got here, I've not even been at Emory for a year, but I'll say that Dr. Rothman at STAR was like, talk to Troy. He's going to help you like figure out how to do this when you get to Emory as well. Troy has been fantastic, like, really has really wanted to foster this collaboration. So I think, we're fortunate. We're going to have opportunities, hopefully, to continue working together.
Well, I think it goes both ways. I've been so fortunate to have such a bright, eager, hardworking faculty to work with and to expand into Emory. So, it's all about knowing the right people here at UF.
Yeah, for sure. Can I ask also for both of you to think with me? You mentioned a couple of things, Rosette, that obviously the data can't tell you everything. Have you thought of sort of mixed methods approaches, or what is the way to sort of validate a little bit of what the data are actually telling you versus what's a sort of a data artifact? And is that an area that PCORI itself might be interested in for some of our members?
So yes, I think mixed methods is encouraged by PCORI, and Troy, you can certainly jump in anytime. Like, for example, I'll tell you with the project that Dr. Flory did from Cornell, his grant, one piece of it was to do the kind of quantitative work that we did within the medical record data for CRN. Another piece of it was like chart abstraction validation, which is kind of getting to mixed methods, but truly a whole other part of it was where he was working with community-based organizations in New York that worked on diabetes research or diabetes translational work, meaning like community advocacy groups for diabetes. And he would interview patients, work with providers. He did a ton of qualitative work there. We didn't participate in that piece of it, but in seeing that's the way they wanted him to do that project, I thought it was a great example of PCORI saying we want multiple approaches to this, because his project really could be perceived as very pharmacoepi, but they always come back to, we want patient engagement. And so qualitative work sometimes is a fantastic way to get that in there too.
Yeah, and we're in the process of a grant here that Betsy Shankman's the PI and an AHRQ are one, looking, using mixed methods approach to look at the use of telehealth during the initial phase of COVID and the acute shutdown, and looking throughout the system from patient care around diabetes and hypertension to how different health systems responded to it, and trying to predict kind of what's going to be happening with telehealth as we go from here. So definitely, as Rosette mentioned, there's a definite interest in mixed methods approaches with it. And I think she mentioned the other big thing is having the stakeholders, the patient stakeholders as part of it. And in many ways that involves a mixed methods approach as well.
Sure, thanks. So we're a little bit out of time, but I did want to hopefully get an answer to this question in the chat from Saria Hassan about, can you speak a little bit about the process of getting access to the data with a research question?
Sure, yeah, and I'll give the quick answer, and I'll say, please feel free to email me if you want a little bit of help just kind of navigating it, and I can at least get you to the right people, I think, to be able to navigate it. So all PCORnet kind of queries go through this thing called the front door. And Troy, correct me if I'm saying any of this wrong, but basically, if you were to go to the One Florida Plus website and there's a subheading there that'll tell you if you're interested in collaborating or getting data access, and it'll take you to this front door. It's really just a survey to assess what project are you interested in doing. It connects you to a member of the administrative team for One Florida Plus. So Troy has a colleague, Liz Manini. I think Liz would probably be the person that gets the front door requests. And she'll kind of guide you through the process of being able to put in a request to access the data. Troy, does that sound about right?
Yeah, Liz is the CEO of One Florida. And so her and her team will look at the request and then oftentimes reach out to you to kind of refine things, and then, go through all the usual stuff, and get it then, when appropriate, reviewed by the One Florida steering committee and down that. But that's the one front door is where they want you to start.
Great. And the one thing I will say, just to be clear, like, this is not the same as like, oh, I want to access census data, I'm just going to download the files. This is more involved. And so I think we need to be sure to budget for that in time. Jithan Varghese, who's on the call as well, he just went through this process for putting together a new grant application and did a fantastic job. It does take some navigation, but that's on purpose, meaning that, it's privacy, confidentiality. This is EHR data that we're moving between institutions. We need to be careful with it. And I actually really appreciate the processes that US has in place for it, because from a security standpoint, it feels so strong to kind of go through that process. But budget time for getting that access.
Will do. Well, thank you again for a great talk, stimulating. And yeah, we look forward to more opportunities of working with Florida's data and otherwise. Thanks so much, everyone.
Thanks so much.
See you soon. Bye-bye.